Dr. Pero, thank you so much for joining us.
It's my pleasure to be here. I look forward to our conversation.
So, Dr. Pero, I am so astonished by the amount of things that you do during the day. I just read that you have these high level positions, but in addition to that, you are a clinical professor of plastic surgery. You are a faculty of Stanford Graduate School of Business. You have written another book. We're going to talk today about your book, Uncaring, how the culture of medicine kills doctors and patients. But before that, you wrote another book called Mistreated. You run two podcasts, which is crazy because I run one and I'm just going crazy. And in addition to that, you have a newsletter. How do you do it all?
I just love the work that I do. I see it as all continuous. You start as a plastic surgeon, fixing children with cleft lip and cleft palate. That was my area of interest. I did surgery, obviously a lot in the United States, but also globally. And then I had the opportunity to lead, to be a CEO in Kaiser Permanente, to be responsible, as you say, for the healthcare of over 5 million people on both the East and West Coast. And now I have the chance, hopefully, to transform at least American medicine, if not global medicine, by moving it from where it's been in the past into the 21st century. So I'm driven by my passion to do it. And as you mentioned, my book, Uncaring, How the Culture of Medicine Kills Doctors and Patients, I'll be discussing a little bit later on. I want viewers and listeners to understand all the profits go to Doctors Without Borders. This is really about how do we change healthcare for the better, for both the people who receive the care, provide the care, and that's been the path of my leadership across my entire career.
And how do you get started in medicine? Was this something that you always wanted to do since you were a little kid? Or, I mean, it has to be. I don't know any doctors who decide to be doctors in the midst of their life. Is this something that, I guess, as soon as you were a teenager, you wanted to help people?
Nope.
Wow.
You now met one, exactly. No, my whole career has been one of serendipity. I went to college at 17 to be a professor, a university professor. I wanted to teach philosophy. And in my first year, the individual, the teacher who was my hero, didn't get tenure. Not because he wasn't very excellent. He ultimately became the chairman at Reed College, but because of his political views. And as strange as it is to say now, I went into medicine to avoid politics. What did I know? I was 17 years old. I was still a little baby sitting there. And along the way, I discovered that it's not all about life and death. There are a lot of other factors. And my goal has been to change those things, both in the system of medicine and in the culture of medicine.
And you went into plastic surgery. I have a question about that. Since the nascence of Instagram and YouTube and all these celebrities, internet celebrities, has the amount of service for plastic surgeons increased, I assume?
So let me answer the question, but then I want to go back to the other point you made about how I chose plastic surgery as my career. The answer is yes. It's one of the only areas of medicine that has, and I think it's the YouTube that you and I are doing now, where we get to see ourselves and we're saying, oh my gosh, I can look better than this. And then people have wanted to get the plastic surgery. And that's combined with the fact, of course, that so much of it is done in an office or in an office operating room, so that the COVID impact relative to the surgical suites that we saw has not affected the specialty as much. But I actually went to Stanford for my residency. I went to medical school at Yale, then I went to my residency at Stanford, and I actually went there to be a heart surgeon. And I was once again disillusioned by the politics, because the people who were getting the referrals were not necessarily the best surgeons. They were the ones who belonged to the right country clubs, who had all the right friends, who could promote themselves the most. And I actually almost dropped out of medicine. I was very disillusioned way back then. But fortunately, a chairman of plastic surgery at Stanford, sent me to Mexico to be part of a team repairing children with cleft lip and cleft palate. It was just, again, serendipity. And I fell in love with the operations. Here you bring a child in whose parents are distraught. You know this child will never have the kind of life that his parents wanted for him. And an hour and a half later, the child comes out with a new face, a new beginning, a new appearance, a new life. The ability to restore so much of the humanness in a short time period. I just fell in love with that, and that became the path on which I wanted to go.
Okay, so now you are in Mexico, and how does that transition into being the CEO of this permanent medical group? I'm sure you are trying to avoid politics one more time, and there you are.
So many steps of serendipity. So I'm in my last year of training, and my plan actually, when I finished my residency in reconstructive plastic surgery, is actually to go back to Central and South America and to fix kids with cleft lip and cleft palate for about a year. And the plastic surgeon in Kaiser Permanente, I'd never heard of Kaiser Permanente, crashed an airplane, not intentionally, but as a tragic accident. And they called me and said, would I come for a few months to help out until they could find a replacement? And I figured, sure, I can delay my trip to South America for a few months. And of course, I never got there, at least in that way, because I loved what I found inside Kaiser Permanente. And I went there to be a surgeon. And then again, it's just this ongoing series of events that you can never imagine. I'm there, my first year, I've only been there 1 year, and I get a phone call from the head of the hospital asking me whether I want to take on the chairmanship of the operating room. Now, I'm sure it's because I have Yale and Stanford and I'm so good. I found out later on, everyone else had just turned them down. I was the last person, and I was too naive and new to realize what was going on. But I said yes. And it was happening because there was a major nurse shortage at the time. And I came up with different ways to fly in nurses. Now it's common, at that time it wasn't. Training programs to advance skill, and was able to address the problem. And that started my pathway up the leadership ladder. Now I continued my clinical work full time, but slowly I took on, or actually pretty quickly, I took on major accountabilities. And then when the opportunity came to become CEO, it was the late 1990s. Kaiser Permanente was in big trouble, down to 2 days of cash. We had to borrow a day of cash to stay in business. By this time, I had a very senior title. I was responsible for the largest of the medical centers there. But I didn't want that job because I knew I'd have to give up my surgical career to become the CEO of such a massive organization, $25 billion in revenue. And so I asked a few friends, will you take the job? And they said, are you kidding me? This is a terrible job. We're down to 2 days of cash. We make it out of existence. And I looked at the people who were willing to do it, and I said, nah, if they do it, I'm leaving because they're not going to be very successful. And I put my hat into the ring. It was a process of selection from the 10,000 physicians, and that's how I became the CEO. And I was able, over the course of my 18 years, to move Kaiser Permanente from being good in quality to #1 in the nation, based on the NCQA, the National Committee for Quality Assurance, being lagging in service to being 20 points better than the competition, J.D. Power and Associates, from having a shortage of physicians to 10 physician applicants for every opening. And I felt that I had an excellent career, and that took me into my next career, which is that I wrote a book, Mistreated, about the experience and about how to make these systemic changes in healthcare. And I realized that if I was going, and I expected about 3 people would read the book, but it became a Washington Post bestseller. I got ahead of Condoleezza Rice, didn't quite catch President Obama, and I had to make a decision. I couldn't keep both jobs because you can't operate, you can't run a business and be around speaking at conferences and consulting to organizations. And I decided the time had come to move on into this third career, which, as you describe, is where I am now. And it's just about as busy as the other two. Being a surgeon, you work all day, you're on call at night. Being the CEO, you work 24 hours a day, 7 days a week. So this is nothing different for me, and I love it, and I enjoy it just as much. They're each different, You know, when you're a surgeon, you take care of maybe 10,000 patients. As the CEO, you have 10 million patients. And now my hope is to have at least 300 million Americans. We can look at the opportunities around the globe where actually I have worked with colleagues in other healthcare systems.
And I had to add that all the proceeds of the books are going to Doctors Without Border, which is an amazing charity work, if that's the proper word to use, helping out the community and millions of doctors who are in the battleground fighting to help save lives. So that's just amazing. Okay, so about this book, can you tell us what is it about?
When I wrote Mistreated, it was about the systemic problems, ones that we know a lot about. We know that the entire insurance world is not functioning very well. We know that medical care outcomes in the United States are not that great. We think they are, but when you look at the data, we're not only the most expensive country in the entire world, double what almost every other country spends, but we lag the other 12 industrialized nations in almost every significant clinical outcome, from life expectancy, childhood mortality, maternal mortality. Our technology is left over from the last century, although actually it's left over from the one before that, because when you ask doctors, what's the most common way you communicate information, do you know what they say? The fax machine. That was invented in the middle of the 19th century. We're not even talking about the 20th century sitting here. Yeah. So I had all these different parts and I went around and talked to people. But as I did, I was aware there was something else holding them back. Because there were opportunities. In Kaiser Permanente, we had lowered the chances of patients dying from heart disease by 40%, cancer by 30%. We had 14 million virtual visits. There were things we were doing. And why wasn't everyone else copying it? And I came to understand this culture of medicine, that what people value, the beliefs they hold, the norms that they follow are not logical. They're just the way you learn in medical school and in residency. You carry them with you. And it's a problem that we would have to solve at the same time that we address the systemic ones for real change to happen.
And isn't it the fact that most hospitals, they make their money when they are curing someone? They don't make money when they prevent someone from getting sick. So, I mean, that's a huge incentive there to continue the ball rolling and just focus on the curing, never mind the preventing. Who cares about that? If we could prevent sickness, then we are out of business.
That's very true, but that again is only half of the problem, because when you look at areas that don't have any financial impact, you also see that there are difficulties sitting in place. What are some examples of that? Well, I often tell the story of Ignaz Semmelweis, who was an obstetrician in Vienna in the 19th century, who inherited the maternity units there, and there was an 18% mortality rate.
Yes.
He was embarrassed, not just by the mortality rate, but the fact that the adjacent facility run by nurse midwives had a mortality 2/3 lower. At the time, the cause of death was puerperal fever, an infection of the uterus spread to the body that killed the woman, and the cause was felt to be miasmas, smelly particles wafting up from the streets. But he asked himself, if the maternity ward is 2/3 lower, they're inhaling the same particles, what's going on? And so, again, serendipity, what we talked about. A colleague of his nicks a finger while doing an autopsy in a woman with puerperal fever, and he goes on to develop a clinical course and die from what seems to be the equivalency, but obviously he's not delivering a baby as the cause of what's going on. And he hypothesizes something's being carried from the autopsy room to the delivery room, either on the hands of doctors or the leather aprons they wear to cover their well-pressed three-piece suits. He says, okay, we're gonna change the aprons before we do a delivery. We're gonna dip our hands in chlorinated water. Lo and behold, what happens? Mortality drops from 18% to 2%. He publishes in a leading journal, and what do you think happens? Nothing. Yeah, exactly. Now ask yourself, it doesn't cost anything to change that apron and wash your hands, right? It doesn't take a whole lot of time to do that. All the explanations we usually give, they don't hold. It's about the culture. Minds of the doctor, I'm a healer, I can't carry disease. The idea that somehow these women are dying because of what the doctors are doing, that would lower their status. See, status and esteem and respect, these are the cultural values that are just as powerful as the money. And you say, okay, that's the 19th century. But today, what's the leading cause of death in hospitals? Hospital-acquired infection. What's the usual organism? Clostridium difficile. Unlike coronavirus, it doesn't go through the air. It's carried on hands. And 1 in 3 times, when doctors go from one patient room to the next, they don't wash their hands. Now understand, there's no cost, there's no time, there's alcohol disinfectants that take 1 second to cleanse themselves, but it's that same piece. And by the way, why did they wear those aprons? Because the more blood and the pus in the 19th century, the more experienced, the more you are. And similarly today, it's the same idea as we wear the white coats that have also been shown, by the way, to carry infection from one room to the next. Little has changed in 150 years because of the culture of medicine, not the systemic issues.
How long did it take before the doctors, the discovery that it was the washing of the hands that was creating all this death, before it was implemented into practice? I think I read somewhere it's about 100 years or so, no?
That's a very good estimate of about what it took before they actually realized it. It took 50 years to Louis Pasteur, found the infection theory and discovered bacteria. But change is slow. And by the way, how long do you think it takes today for a great idea, not a good idea, a great idea to become standard practice in American medicine? How long?
I'll tell you something, it depends on the problem, because I know that when Viagra was discovered, it spread to the world in a few weeks.
And the same with anesthesia. But yeah, it takes today an average 17 years.
Oh, wow.
And now look at one other fact. 30% of what doctors do today has been shown by the Mayo Clinic and through New England, a review of New England Journal of Medicine articles, to add no value. 30%. Now again, we might say that that's because of the money, but we also have to recognize that it's also because of the physician culture. Because in the minds of the doctor, anecdotal experience, the same problems of the past. Yeah, I remember a patient who did well. Yeah, but you don't remember the 3 who didn't. When the data is so clear, we still go back to intuition, personal preference, rather than following the science and using technology to move clinical outcomes forward in positive ways. The culture of medicine and the systemic problems are both equally problematic.
So you opened the book telling us the story of how most of the people hospitalized for coronavirus, most of the deaths were because people have chronic diseases and we are not taking care of that. So our problem, our death rate was way before coronavirus. It was because we just the healthcare system is not taking care of all these other additional problems that are happening in society today. So can you tell us more about that, please?
Absolutely. So during the coronavirus, we saw the culture of medicine both at its greatest and its most problematic. And I want viewers and listeners to understand that I wrote the book not to castigate medicine, but to make it better. As you know, in the end, I talk about the love of my parents. My father adored my mother. She could do nothing wrong. She was perfect. To the day he died, he would have given up his arms and his legs if she could have lived for 2 more days. My mother saw my father for the reality of who he was. He loved her. She loved him just as much, but she wasn't blind. And that's how I see this process. Coronavirus comes ashore, doctors are heroes. They don't have the protective equipment they need, so they put on garbage bags and they put on salad masks in place of N95 masks. When they have a patient who can't breathe, they pass the tube through the mouth into the lungs. As the tube goes through the vocal cords, every patient will cough, spewing virus in their face. When 2 patients needed a ventilator and there was only 1 machine, they figured out how to put them both on 1 machine. Something that had never been done, in fact, never had been thought about. They were heroes. And yet, as you pointed out, 88% of people had 2 or more chronic diseases. Diseases that could have been addressed. Hypertension was the #1 reason for admission. Across the United States, hypertension is controlled 55 to 60% of the time. It's the #1 cause of strokes, kidney failure, and major contributor to heart disease. When I was the CEO in Kaiser Permanente, we controlled it over 90% of the time. Our doctors were great, but they were no different than other doctors. The medications were the same. What was really different? The culture. Because when you're working, as you say, in a capitated system, so there's advantages for prevention, but in a culture that values it. When you're in a culture that values primary care, as much as they value interventional cardiology, the ability to prevent vascular occlusion to the heart rather than simply unblocking it, you start to see those changes. And what's interesting to me is, despite this information that we have about chronic disease, I haven't heard a single medical society say, mea culpa, we were guilty, we'll do better. It's ignored because that's the culture, what you value. What we know is that physicians say, I treat every patient the same. It's a high value, except early in the coronavirus era, when 2 patients came to the ED with identical symptoms. One was a Black patient, was a white patient. Testing was done twice as often on the white patient, in spite of the fact that mortality was 3 times higher for the Black patients. When pain medication was administered, they administered 40% less pain medication to Black patients than white patients. Maternal mortality is 3 times higher, except when the attending physician is a Black physician. All this information is ignored because it doesn't fit inside the way the culture tells doctors, this is who we are, elevated status and high esteem. Now, I want to be clear again for viewers and listeners. I love doctors. They deserve all of the credit, but they also, and what needs to happen is to recognize the shortcomings and use that not as something terrible, but as a great opportunity, an opportunity to actually save lives. We trail other nations around the globe 5 years in longevity of life. We should be the #1 leader. We should have the opportunity for people to live 5 more years of a healthy, fulfilling life.
Right. When you talk about culture, not only the culture in the healthcare industry, but also business in general. I mean, we have McDonald's and Coca-Cola telling us that we should eat 1 more hamburger and drink 1 more Coke full of sugar. And we have, the automobile industries telling us that we should buy a car instead of walking 15 minutes to the store. So all these things add up, and we do less and less physical activity. We eat more and more garbage. I don't know any other way to say it. And this is a message that is coming to our whatever means of information we have every day. Eat 1 more hamburger, buy a car. San Francisco or California is full of scooters, so people don't have to walk 5 minutes from one place to the other. So I think it's a shared responsibility of all different industries that contribute towards this unhealthy lifestyle.
I concur completely. Again, it's the systemic problems and the cultural ones. And you've made a great point. It's not just in the culture of medicine, it's in our entire society. I do believe that an obligation of the healthcare system and the obligation of physicians in it is to help lead this broader change, because the ultimate measure is the health of individuals and their life expectancy. And when we fall short, that is when we need to say we should do better. And that's a cultural statement, not a economic or financial one.
How much truth there is? I've been hearing news about some private companies um, initiating their own health plan because they figure out that preventive medicine is cheaper than curing a person after they have been attained with some kind of medical problem.
It's happening, but it's not happening fast because of the physician culture, the medical culture. But I will say, in the post-coronavirus era, I believe it's going to happen more rapidly. And I write about that in Uncaring, how the culture of medicine kills doctors and patients, because what I see is that the federal government will have borrowed $8 trillion. They got to either repay the money or pay the interest. States by law have to have a balanced budget. And they're going to have higher expenses for unemployment and for Medicaid and lower tax revenue. And small businesses were hammered. They're going to have to get back onto their financial feet. And everyone's going to look to medicine as an opportunity and a place to lower costs because it's a quarter of the federal budget and it's the fastest rising piece for most businesses. And I think we're going to face a situation where if you want to lower cost, you can't do it in the traditional fee-for-service world because physicians will just do more and more and more and costs will stay elevated. You have to either do it by one of two ways. You can ration the care. Say to people, you're too old to have heart surgery. Say there's a line of a year to get orthopedic consultation for a joint replacement. You can't have that medication, it's just too expensive. Or they're going to transform medicine in a way that's going to change how doctors are paid. They're going to get paid on a capitated basis, not at the insurance system level, but at the delivery system level. And when they're paid in that particular way, what you see is that the culture starts to evolve. Slowly at first, physicians are going to have difficulty giving up what they valued in the past. They're going to go through the 5 stages of grief of Kubler-Ross. They'll be in denial and they'll get angry. Then they'll bargain to keep a little bit and they'll get depressed. Ultimately, though, if this is the new normal, they're going to have to reach acceptance. And now start to think about it. When you're paid on this capitated basis, now you start to value prevention. Now you start to value not getting a complication of chronic disease. Now you start to value patient safety and avoiding a medical error. You start to elevate the role of the primary care physician, not at the expense of the specialist, but as partnership with them. And as you know, I have in the book, the 5 C's. You have to confront the problem and understand the challenge of the American healthcare system. We haven't done it. We've been blind to it. You got to commit to changing. Physicians need to help lead that process along with other healthcare professionals. You got to connect with other people. You can't solve it alone. It's not people doing more work. It's working together. You have to collaborate and find alternative and better ways. And I think you have to also look at contribution, by which I mean that doing for others often gives you more satisfaction than getting for yourself. And I saw that on my global surgery trips. You know, did a lot of cleft work in other countries. We sent people to Liberia in the context of Ebola. We did it with Doctors Without Borders. They had to have IVs running into their arms because it was so hot inside the suits they had to wear in the heat of Africa that they sweated so much they would have lost so much fluid and passed out if they weren't having IVs going in. And they came back the happiest doctors you've ever seen because purpose is so vital. That's why you become a doctor in the first place. And I think the culture of medicine has robbed us of much of that. So I have an optimism that it's all going to change, that the system and the culture will evolve together, but I don't underestimate how difficult and painful that process is going to be.
Wow, Professor Pearl, this is so amazing, all this information you are giving us. I wonder if you could tell us one more time the title of the book, and also can you please tell us about the 2 podcasts that you have, your newsletter? I mean, you are everywhere and you deserve to be everywhere because I see nothing but valuable and inspiring information.
The best place people can find out about all of this is through my website, robertpearlmd.com. There they can order the book. It's just an access to all the people like Amazon and Barnes and Noble that provide it. I don't make any money. Any profit goes to the charity Doctors Without Borders. They can listen to the podcast. Fixing Healthcare is a monthly podcast. It's in its 5th season. I've run very, very famous guests. And this season was dedicated to the culture of medicine. And Coronavirus, the Truth, comes out every other week. And we look in detail. We've had 36 episodes looking at this terrible pandemic and the tragedy it's created and the opportunities that are there. None of these programs have any advertising. Again, it's all done for the benefit and education of people overall. I have a monthly newsletter, which they can also sign up for by going to the robertpearlmd.com website. It has information on articles and information on new subjects, has the request of people to participate in reader surveys. And I learn so much from the people in the audience. As you say, I teach at the Stanford Graduate School of Business at the Stanford Medical School. But what I'll tell you, what every professor will say, is you always learn more from others than you teach them and tell them. You know that as a podcast host. And I encourage all of your viewers and listeners to go to the website, sign up for the newsletter, hopefully buy the book, and get back to me. Tell me what you think, whether you love it, whether you hate it, whether you agree, whether you disagree. The dialogue and the debate is what's going to move American medicine forward. And I'm hoping one day restore it to being the best in the world.
Dr. Pearl, thank you so much for your time.
My pleasure. It's been a privilege to be on your show. Thank you so much for hosting it.